Kita mula dengan umur kitab dulu.
Okay, should I start? Okay, Assalamualaikum warahmatullahi wabarakatuh. So today we will be discussing a topic on immunization. So I am Nik Kabila Iman binti Abdullah. Next slide. Alright, so this is our outline of presentation. I'll present the first 2 points, concept of immunization, active and passive immunization, and also concept of booster. And then the second point is the immunization program, about the immunized disease that are listed in the Ministry of Health immunization schedule. And then the third and fourth will be presented by Nur Aina Izzati about the contraindication and adverse effects of vaccination, and also the additional vaccines in Malaysia and their benefits. And then the last 2 points will be presented by Faiz Imran. So this is about the controversy surrounding vaccination, how to tackle the anti-vaxxers or the vaccine refuser. And then the last one is the evidence-based medicine. We'll discuss about the problems with the dengue vaccine. Okay, next, please. Okay, so I'll start with the concepts. Okay, next. Next, okay. All right, so first one is the concept of immunization. So now let's look into several basic terms associated with immunization. So the first one is immunity, in which it is a protection from an infectious disease. So if someone is immune to a certain immune to a disease, then the person can be exposed to it without becoming infected. And vaccine is a product that stimulates a person's immune system to produce immunity to a specific disease, and protecting the person from that disease. Vaccination is the act of introducing a vaccine into the body to produce immunity to a specific disease. And lastly, immunization is a process by which a person becomes protected against a disease through vaccination. So this term can be used interchangeably between vaccination and also inoculation. Okay, next. Now let's look into the concept of immunization. So there are active and passive immunization. So active immunity per se is when the body's immune system is actively producing antibodies, whereas passive immunity is when the body is given the the antibodies. They're not actively producing themselves. So active immunization is the use of vaccine to stimulate the immune system to produce a protective immune response, whereby the passive immunization is the direct transfer of administration of antibodies to a non-immune person. So this one, the passive immunization can be acquired through, for example, maternal passive immunization, where the infants receives antibodies from the mother through placenta or via breast milk. There is a direct transfer of the antibodies there, or even through transfusion of blood products or transfusion of antibodies through blood transfusion to a non-immune person. Okay, so since the body needs time to produce the antibodies, so they have active immunization have a much slower onset as compared to passive immunization. With passive immunization, which provides immediate protection to an infection. However, the protection from passive immunization is temporary, is short-term immunity, whereas for active immunization, it lasts much longer, probably several years or even for a lifetime. And active immunization is not applicable to immunodeficient hosts. So this is because immunodeficient individuals may not be capable to elicit or to initiate a proper immune response, since we depend on the person's immune system to produce the antibodies, whereas passive immunization is applicable to immunodeficient hosts. And then lastly, active immunization, it generates an immunological memory. So this is the ability for the body to quickly and specifically recognize an antigen that the body has previously encountered and initiate a proper immune response. So this allows the body um, to uh, to to react faster. And passive immunization, it does not generate an immunological memory. Okay, next. Okay, so now let's look into the concept of booster. So booster is basically to increase an effect, to help increase an effect. So booster in vaccination is an additional dose that is given periodically to boost the immune system. So there's okay, so now let's look into the diagram. There's this first vaccination which will produce a slight increase in the antibody concentration. So this is the primary immune response, where it is the first exposure of the body to an antigen, but the antibody concentration will reduce over time. So upon second vaccination, it will produce a secondary immune response, which is much faster and larger because this is because of the activation of the memory B cells that were induced during the primary immune response. So this allows the body to respond rapidly to a second exposure by the same antigen. But over time, the antibody concentration will also reduce, and that is when the booster is given. It is to boost the immune response or to renew the effect of the immune system. So that's the concept booster. Okay, next. So now let's look into the immunization program, the immunized diseases that is listed in the national immunization schedule. So this is basically the previous version of the national immunization schedule, but I'm not gonna I will explain in detail in the later, so I just put it here so it's easier to differentiate. Okay, next. So this is the latest national immunization schedule, which was updated in November 2020. 2020. So as an overview, there are two updates in the latest schedule as compared to the older one. So the first update is the 6-in-1 vaccine, and then the second update is the pneumococcal vaccine. So now let's look into the vaccines one by one. So there are at birth there are two vaccines that are given. Two vaccines that are given at birth. First one is BCG vaccine. BCG vaccine, which is targeted to prevent tuberculosis. One dose is given at birth, and then second one is hepatitis B monovalent vaccine, which is also given at birth. Okay, and then there is this 6-in-1 vaccine. So about 6-in-1 vaccine, previously it was 5-in-1. 5 DTAP, IPV, and also HIV, which is targeted to prevent 5 diseases: diphtheria, tetanus, pertussis, polio, and also Haemophilus influenza type B. And then the recent addition, the latest addition to the 5-in-1 is the hepatitis B vaccine, making it 6-in-1. So target hepatitis B. Okay, so what are the significance of this change is basically, what is the difference actually? What is the difference between the hepatitis B vaccine that, oh no, okay, that is given at birth, and also the one that is given in combination with the same vaccine. So can you go back to the previous slide? Okay, so if you look in the previous vaccine, the hepatitis B vaccine was given separately in 3 doses. 1 dose at birth, and then followed by a dose at 1 month, and also at 6 months. So 3 doses are given separately. So in the recent, sorry, but can you go to the latest one? Go back to the next slide. Okay, so in the latest one, only the first dose is given separately. Only the first dose is given separately at first. The other 2 doses are incorporated or is given in combination with the 6-in-1 vaccine, which are given at 3 doses, which are given 4 doses, 3 primary doses at 2, 3, and 5 months, and then followed by a booster dose given at 18 months. So what is the significance of this change? Is basically the reduction in the total number of injections. So previously, 7 injections are required to prevent 6 diseases, but now in the latest scale, only 5 injections are required to prevent the 6, or prevention of 6 diseases. Okay, so this is to parents to help parents to follow the schedule. Also, it's easy for the baby injection as well. Okay, now moving on to the other vaccines, which are the measles vaccine. This one is only for given 1 dose at 6 months, and then there is other vaccine, mumps and rubella vaccine, with for all states, including Sabah, given 2 doses at 9 months and also at 12 months. Okay, and there are 2 booster doses for MR and D, rubella and diphtheria and tetanus. So the booster dose given at 7 years old at standard 1, stage 1, and a HPV vaccine given only for girls, given during 13 years old at form 1. And then a booster dose for tetanus is given at 15 years old. And then another vaccine indicated for only Sabah, only Sarawak, the Japanese encephalitis vaccine, given 2 doses at 9 and 21 months old. Okay. And the last one is the pneumococcal vaccine, which is the latest addition to the immunization schedule, which is targeted to prevent bacterial pneumococcal infections. So this vaccine is given in 3 doses, 2 primary doses, which are given at 4 and 6 months, and also followed by a booster dose given at 15 months old. So about this pneumococcal vaccine, it was previously already available as an additional vaccine, but only up until recently, probably earlier 2020, last year, there are requests to include this vaccine into the national immunization program schedule. But So the initial plan was to include this vaccine in June 2020, but because of the pandemic, it got delayed and postponed the inclusion. So this pneumococcal vaccine is only available from in December 2020 last year. Okay. So this addition of this pneumococcal vaccine is especially important for the lower income families because previously they can afford to pay for this additional vaccine, but now in the recent schedule, this pneumococcal vaccine is provided for free under the National Immunization Program. Okay, that's about this schedule. Okay, so these are just list of diseases that are affected by the in the existing vaccine, also the local vaccine. So that's the name that they are aggregation. Okay, so I guess that's all for me.
Can you guys hear me? Okay, so Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Aina Izzati binti Abdul Aziz, metric number 1810196. And I will continue the presentation with the next topic, which is the contraindications and adverse effect of vaccinations, and also the additional vaccines in Malaysia and their benefits. Next slide. Okay, so for contraindications, before vaccination, the medical staff should make sure that the individual to be vaccinated does not have a condition or a history of a condition which could increase the risk of a severe reaction. And for contraindications, it can either be an absolute contraindication or a relative contraindications. So let's talk about absolute contraindications first. So what is absolute contraindications? They are any conditions in a recipient that increases the risk for a serious adverse reaction to vaccination. And they are also conditions under which vaccines should not be administered to the person. Majority of the absolute contraindications are temporary, so vaccinations often can be administered later when the condition leading to a contraindication no longer exists. So for any vaccine, the absolute contraindication is if there is any presence of a severe anaphylaxis reaction to previous dose of the vaccine or to a component of the vaccine. Next, we are going to talk about the absolute contraindications for live vaccine and killed vaccine, which are different. So for live vaccine, the first one is immunosuppressed children, such as children with malignancy, irradiation, leukemia, lymphoma, post-transplant, and also primary immunodeficiency syndromes. And the second one is pregnancy, especially live vaccine, because it has theoretical risk of virus transmission to the fetus unless there is significant exposure to serious condition like polio or yellow fever, in which case the importance of vaccination will outweigh the risk to the fetus. And the third one is if the person is on chemotherapy or less than 6 months after the last dose. And the next one is if the person is on a prolonged course of high-dose corticosteroids such as prednisolone. And the next one is if the person, if given, has been given another live attenuated vaccine, including BCG, less than 4 weeks ago. So for your information, we can give live vaccines together or simultaneously at different injection sites unless we use the combined preparations, which can be injected at once because this does not impair the antibody reaction and it also does not increase adverse effect. So if the vaccines are not administered simultaneously or together, then we need an interval of more than 4 weeks before we inject another vaccine. And the last one is if the person is within 3 months following IV immunoglobulin treatment. For killed vaccine, the absolute contraindications, so killed vaccines are generally safe except in severe local induration involving more than 2/3 of the limbs, and also if there was any severe generalized reactions in the previous dose. Next slide. Okay, so we move on to relative contraindications. So generally, relative contraindication means we need to use precaution. So precaution are events or conditions to be considered in determining if the benefits of the vaccine outweigh the risk for vaccination. So it is basically a condition in a recipient that might increase the risk for a serious adverse reaction, or it can either cause diagnostic confusion, or it can also compromise the ability of the vaccine to produce immunity. So for example, if we do not vaccinate a person who is moderately or severely ill to avoid diagnostic confusion between the underlying illness and also the side effects of the vaccination. Okay, so the first relative contraindications for vaccination is for all vaccine, if there is any presence of a moderate or severe acute illness with or without fever. So the decision to administer or delay vaccination depends on the severity of the symptoms and etiology of the condition. And the risk-benefit decision will exist until the patient is considered recovered. And for the next one, for DTaP vaccine, if there is any history of Arthur's type hypersensitivity reactions after a previous dose of diphtheria toxoid containing or tetanus toxoid containing vaccine, and in this case, we need to defer vaccination, and the risk to benefit decision will exist until at least 10 years have elapsed since the last tetanus toxoid containing vaccine. And for DTaP also, if there is any progressive neurological disorder, including infantile spasms, uncontrolled epilepsy, progressive encephalopathy, and we need to defer a DTaP until neurological condition and neurologic status has been clarified and stabilized. And for DTaP and influenza vaccine, if there is any history of GBS, which is Guillain-Barré syndrome, less than 6 weeks after previous dose of tetanus toxoid containing vaccine. And for measles, mumps, and rubella vaccine, if there's any recent receipt of antibody containing blood product, and the risk to benefit decision exists for a predefined interval depending on the product. Next slide. Okay, so we will now discuss the specific side effects commonly caused by the vaccine. So the first one is for the BCG vaccine. The common side effect is BCG adenitis may occur. And for hepatitis, there might be local reactions such as swelling or pain. And they can also be fever and flu-like symptoms in the first 48 hours. And rarely, erythema multiforme or urticaria can also be present. And for diphtheria tetanus vaccine, there might be swelling, redness, and pain. And there might also be small painless nodule at the injection site. And fortunately, these are harmless. And patient can have transient fever, headaches, malaise, and rarely anaphylaxis. And neurological conditions are rare. And for pertussis vaccine, there might be local reaction, and it is considered severe if it involves more than if it involves 2/3 of the limbs, and there can be severe systemic reaction, anaphylaxis, encephalopathy, high fever, inconsolable crying, and also hyporesponsive state. Next. For measles, mumps, and rubella vaccine, in general, for the MMR vaccine, there might be transient rash in 5% of the person receiving the vaccines. There can also be fever, upper respiratory tract infection symptoms. They can also be febrile convulsions and encephalopathy. And for mumps, there might rarely be transient rash, pruritus, and also purpura. There can also be parotitis in 1% of the person receiving the vaccines, and they can also be orchitis and retrobulbar neuritis, which are very rare, and meningoencephalitis are also mild and rare. And for rubella, which is given as MMR, they can be rash, lymphadenopathy, thrombocytopenia, and also transient peripheral neuritis. And they can also be arthritis and arthralgia in 3% of the children and 20% of the adults. Next. For IPV, they can be local reactions whereby the short sites can have swelling, redness, and also pain. And for Haemophilus influenza type B vaccine, they can be local swelling after vaccination, and it can last up to 24 hours in 10% of the vaccines. And they can also be malaise, headaches, fever, irritability, and inconsolable crying. And very rarely, they can be seizure. And for Japanese encephalitis, they can be local redness, swelling, pain, fever, chills, headache, and also lassitude, which is fatigue. And the last one, which is the HPV vaccine, the patient can have headache, myalgia, injection site reactions, fatigue, nausea, vomiting, diarrhea, abdominal pain, pruritus, rash, urticaria, myalgia, arthralgia, and also fever. Next. Okay, so let's talk briefly about the additional vaccinations that are available in our country and also their benefits. So there are vaccines for other common childhood diseases which are not covered by the Malaysian National Immunization Program, and these are called the additional vaccines. And many of the vaccines can also protect against common childhood diseases, and it can also prevent disease outbreaks and epidemics. And they are as important as routine immunization in protecting children from vaccine preventable diseases. And these vaccines are available at private hospitals and clinics for a fee all over our country. So the table below shows the suggested immunization schedule for vaccines that are not listed in the National Immunization Program. So the first one is we have the pneumococcal conjugate vaccine, and it is recommended to complete 3 doses within the first year of life, starting at 6 weeks of age. And for number of shots, it can either be from 1 to 4, depending on the age. And we usually administer it after 2 months and can be administered up to 9 years of age. And the next recommended vaccine is meningococcal vaccine. It is recommended for children traveling to a high-risk area, and a single dose can provide immunity up to 3 years. And we usually give the shot once every 3 to 5 years. The third one is rotavirus. And this vaccine, it is recommended first dose to be given after 6 weeks of age. And for varicella or chickenpox vaccine, it is recommended for children 12 months and above, whereby we give 2 doses more than 4 weeks apart. And the last one is hepatitis A. For children above 1 year, we give 2 doses given 6 to 12 months apart. Next slide. Now let's talk briefly about the benefits of this additional vaccine. So for pneumococcal vaccine, it can help prevent pneumococcal diseases caused by those of the Streptococcus pneumonia strains included in the vaccine. It can also help to protect against invasive pneumococcal diseases such as meningitis and acute otitis media among infants and children. And it can also help to reduce the incidence of pneumococcal disease. And it is usually available in 2 different types, which are either polysaccharide or conjugate vaccine. And the next one, for meningococcal vaccine, it can help prevent meningococcal infection caused by Neisseria meningitidis. especially for protection during the ages when they are at highest risk of meningococcal infection. And in this vaccine, it helps protect against 4 types of bacteria that cause meningococcal disease. And for travelers going to the sub-Saharan or Africa, which is the areas with current outbreaks of the meningococcal vaccine, it can also help prevent meningococcal infection. And for rotavirus, it is for prevention of diarrhea and vomiting caused by rotavirus infection in infants.
So, rasa boleh skip lah ni slide ni.
Okay.
Saya
I
rasa ni
think you
sama
can
slide
read
ni.
by yourself.
Okay, okay.
I think that's all from me.
Okay, thank you.
Assalamualaikum warahmatullahi wabarakatuh. I'm Faiz and I'll be talking about the controversy of vaccines. So beginning with that, vaccines, people have been hesitant to take it since the beginning of the age of the vaccines. Vaccine hesitancy, which can be defined by WHO as a delay in acceptance or refusal of vaccine despite availability of vaccination services. So, as you can see in the diagram, we have 3 types of vaccine hesitants. We have the vaccine skeptics who are willing to follow the facts. They take a more scientific approach, evidence-based. Vaccine refusers, people who refuse the vaccine, and at the same time, they don't think about why they're refusing the vaccine. They just think they're doing the right move. But these vaccine refusers are still open to arguments and opinions as long as they are credible. But in the extreme part, you have the vaccine deniers who are not open to any change of mind. They will spread their propaganda. They don't want other people to take vaccines. They are the opposite of doctors. They would deny vaccines. They don't want other people to take vaccines. And if you try to persuade them, it will be most likely counterproductive. It's not going to work. So with that being said, when we spread our message about vaccines, we have to adopt a set of rules and we have to ensure our goals. So the goal when you make a public discussion, and this is not just like a forum, it could be on the internet or any legitimate platforms. But anyways, the goal is to make the audience more resilient against anti-vaccine statements and stories. At the same time, we support the vaccine hesitants in their vaccine acceptance decision. So we want to discredit the anti-vaxxers and we want to support the people who are switching sides. They want to take vaccines. And this way we have to adopt 2 rules. The first rule is that when you make a public discussion, the target is the audience, not the vocal vaccine denier. So when you make a public discussion and a vocal vaccine denier tries to confront you, you don't reply face to face. He asks a question, you reply to the crowd. And bear in mind that when you make a public discussion, since it is futile to convince the vaccine denier, keep in mind that the goal of the public discussion is to not change the mind of the vocal vaccine denier. The goals, as mentioned, is to discredit the vaccine denier and bring in the vaccine hesitant. The second rule is that we aim to correct the content and unmask the techniques that the vocal vaccine denier is using, which I will explain right now. So when a vaccine denier confronts you, there are a couple of elements in their argument. So I will go through these elements one by one and how to correct them. Like firstly, let's just say they tell you, hey, this disease is not a threat anymore. This disease is long gone. So when he makes that remark, you have to find the element and you have to correct it with a sensible answer. For example, If he says this disease is not a threat anymore, you can say vaccine, preventable diseases still cause millions of deaths annually. Prevention is better than cure. And plus, he may not be aware of the effects of herd immunity. So next, we have alternatives. So and so is a good alternative, or not just this. People can say, why would we need vaccines when natural immunity is already enough? Again, we have to bring in the facts. There are no equally safe and effective alternatives to vaccinations. Effectiveness, vaccines didn't save us. But however, vaccines are the most effective method of preventing serious diseases, as proven by science. Next is trust. These days, people even believe that the COVID-19 vaccine is a threat by Bill Gates to plant microchips into your brain. Obviously, that's not the case. It's all conspiracies, which I'll explain later. But if you get confronted with that statement, you have to assert that we could care less about that. We just want the whole community to sustain a long, healthy life. And finally, the issue of safety. Vaccines can cause, example, autism. But if it does cause autism, I'll explain about that later. But any correction, we can say any theoretical risk to the individual and society is far outweighed by the risk to one and all of not doing so, meaning prevention is better than cure. And since we're in Malaysia, I know we'll be talking about Maqasid al-Sharia later, but since we're in Malaysia, I will talk about religious beliefs a bit. Vaccine X could contain human fetal cells, gelatin, but of course we have the facts. Religious authorities have already issued a fatwa to allow the utilization of these vaccines in the context of darurat. So that's correcting the content. This is the subset of rule number 2. We correct the content, and next we unmask their technique. So these are the techniques that the vaccine deniers use. They refer to conspiracies, which is not sensible. The conspiracies, anyone can make a conspiracy theory, more so than any person can write anything on Wikipedia. They also use fake experts, fake authorities that are not well recognized. And speaking of not well recognized, they take selective. They are very selective. They refer to all these isolated papers, all these minor, not to say minor, but different papers that challenge established scientific consensus. They also put up impossible expectations. They think that they expect that if a vaccine should work, there shouldn't be any side effects, and it should work 100%. And they also use misrepresentation, and false logic. They jump to conclusions, false analogies. So these are the techniques they use. And now we need to unmask the technique. So when they present the argument, they say, for example, they say vaccines are actually a government employ to brainwash the whole country, according to so and so. So first of all, you find their tech, you correct the argument. We're sorry we lost your trust, but we hope to regain it back. And vaccines give you a sustainable, long, healthy life. You correct the content. And number 2, you unmask that technique. This is kind of like a counter attack. So if they refer to conspiracies, you can say this conspiracy theory ignores the evidence produced by independent scientists. Where vaccines are used, people live healthy lives. If they use fake experts, you can say these experts that you refer to are against the public opinion or scientific consensus. Same thing with selectivity. If they take all these isolated papers, you can just say, Miss, these papers are not based on the general scientific consensus made by the majority of scientists. And they also might put up impossible expectations. well, this vaccine doesn't, I heard this vaccine does not really work, or this vaccine is completely useless and vaccines are used for, or it's all profit oriented. But you can reply that Mr. or Miss in science, that in science, these are called impossible expectations. Either way, the theoretical risk again far outweighs the risk of having a preventable disease. And plus, no medical product or intervention, be it aspirin or heart surgery, is guaranteed to be 100% safe. Nothing is 100% safe. Yep, and that's pretty much about how to counter vaccine deniers. Again, rule number one, your audience is the people, not the vocal vaccine denier. So avoid face-to-face. And rule number two, we correct their content and we unmask their technique. If they put up an argument, we bring out the facts and then we counterattack that your argument is based off unreliable sources or theories. And of course, this goes without saying, when you want to engage in a public discussion, you have to be a trained health professional. And aside from that, also you have to practice. No one's born a good speaker. And of course, you have to, do all when you do public speaking, you have to maintain eye contact. You have to do all these sorts of stuff to gain the public's trust and put up a good impression. Now let's talk about the dengue vaccine, Dengvaxia, or also known as CYD, TDV. It is a live recombinant tetravalent dengue vaccine. So about this vaccine, the overall efficacy has been mentioned since you are injecting 4 variants into the body. Then you would gain immunity on the 4 serotypes. But how you can see that these serotypes, the efficacy of the vaccine varies, depends on the serotype, and it also varies according to age and seropositivity. I'll talk about that later. But for now, why there is controversy against this vaccine? It all started in Philippines when they first released the Dengvaxia. So Philippines adopted it and said, okay, let's mass immunize. Let's immunize our citizens. I think about 700,000 children are immunized with the vaccine, and about 50,000 plus volunteer adults are also injected with the vaccines. And so what happened after that? After the mass immunization, Sanofi Pasteur, the inventor, the one person who made the vaccine, said that the vaccine is not as optimized if you inject it in a person who has not got dengue yet, someone who is seronegative. The vaccine might be dangerous to people who have not been infected with dengue yet. So in the result, I think about 600 children died. And so what happened, they had to stop the immunization. They stopped everything. And a lot of the Department of Health are under attack cover. Which one? Because how can you let these deaths happen with the vaccines? So after that, after they stopped the mass immunization, they did a small research. Independent task force was assigned to check in about these deaths. So they took 14 death cases and they assessed it according to the WHO's causality assessment of adverse event following immunization. And out of these 14 cases they pick, about 3 of them fall under category A1, which is consistent with causal association, meaning the vaccine has a causal relationship with the deaths, and 2 of which implicated vaccine failures, meaning that these 2 cases, the vaccine failures, they have been injected, but for somewhat reason, the vaccine didn't work, which because of that, they end up getting the disease that was not supposed to be there, but it came because the vaccine failed. And 6 of those cases are under category B1, meaning that they have a causal relationship, but there's not enough evidence to prove that the vaccines cause the death. And 3 are under the inconsistent category, and D are under indeterminate category. So what I'm trying to say here is that there has been a lot of controversy, and the controversy is very, it's quite huge, because that when these deaths occur, the media was very, very quick to spread about how bad these vaccines are. And aside from that, there also has been some theory about some political corruption. But the point being that these vaccines are not as bad or not as severe as we thought it to be, as pointed out by these inconsistent relationships. And again, let's bear in mind that about 700,000 plus people were inoculated with the vaccine, and some of which did develop the immunity. So what is WHO's recommendation on getting this dengue vaccine? Firstly, it is important that you have to be infected with dengue virus before. You have to be seropositive, because as shown in the case of the Philippines event, is that increased risk of hospitalized and severe dengue in seronegative individuals. So if you have not been infected with dengue before, then don't take the vaccine. And also the increased risk of hospitalization happens in children in about 2 to 5 years old, but this increased risk is not seen in ages 9 years old and above. So if I were to recommend it, number 1, you have to be infected with dengue before. Number 2 is that you have to be above 9 years old. Yeah, and 9 to 45, it could be lower, depending if the dengue incident is very common in your place. And that should be all from me. Yeah. Thank you. Any questions?
Okay, is that all?
Yes.
Okay, semua kena turn on video saya orang record kan? Untuk attendance. Let's see apa lagi. Okay, I think that's all. Ada any questions about immunization? Actually, immunization you boleh baca je lah. It's nothing. Just read. But definitely a lot of questions will come out from immunization because there's a lot of potential questions. It's just that I think one of your friend yang female tadi, I think siapa, you've mentioned about indication to contraindication for vaccination kan. You've mentioned about immune antibody. I think you've mentioned antibody blood product kan, antibody containing blood product kan. One of the issue, and especially in neonates, in NICU, because a lot of neonates, we transfuse them with whole blood, with packed cell or whole blood lah, but usually whole blood. Nowadays most of the time we transfuse with packed cell rather than whole blood, except for in some condition macam exchange transfusion, memang kita transfuse with whole blood rather than packed cell. But remember, even in packed cell, there is some antibody contaminated contaminants, antibody contaminants in the packed cell. So actually, you have to postpone the live vaccine. So it's very important. When you become a doctor later, when you work especially in NICU or in young children, you have to think of this before you discharge patient. All this has to be documented because, for example, if the child underwent exchange transfusion and then you discharge the child, the baby, And then patient is due for like upon discharge kita akan beri BCG. Okay, maybe in hospital kita delay lah, kita postpone lah BCG. Sometimes kalau kita ingat kita postpone, but most time we don't postpone. We just give BCG upon discharge. So BCG yang bagi ONG, it's not us. Usually ONG nurse yang akan bagi BCG. So at the end BCG will not work because this is live vaccine. You dah transfuse patient dengan whole blood tau, 40 ml, 20 to 40 ml whole blood. And then sometimes if you transfuse a lot of blood atau patient got hemolytic disease in newborn kan, severe jaundice with scoop positive, so you bagi IVIG, then you have to postpone the live vaccine kan. So sometimes if you don't document properly, the child will be discharged and will be given MMR. MMR first dose bila? Berapa bulan? So if you give high dose IVIG, how long shall you postpone? How long you should postpone the live vaccine? Siapa yang present tadi? Yang contraindication tadi? Semua tadi present.
I know.
Aina.
Um,
Okay, so you present tadi
yes,
kan?
can you hear me?
Yes. So how long you should how long
Yes.
should we postpone the live vaccine after IVIG administration?
I'm not sure. Is it 6 months?
Is it? Okay, I nak you pergi CDC website. Okay, go
Can
to
you hear
CDC
me?
website. Yes, we can. So go to CDC website. Okay, check it out. Okay, check it out. How long shall you postpone live vaccine for every antibody containing product? So this include because we give a lot of antibody to babies, especially we give human IVIG, we give logum, anti-D kan, anti-rhesus or anti-D antibody. We give visit kan, varicella zoster antibody. We give Paxel, we give FFP, we give cryoprecipitate. So these are all antibody serum containing product kan, so they are the antibody. So how long shall we postpone the live vaccine? Because it depends on the dose. So Aina, you check. Okay, you check sekarang, pergi CDC website, check, and then tell us later. So ada soalan lain tak? So how long does actually in general kan, this I mean the vaccine is actually a artificial kan, active artificial immunization kan. So how long does protection confer? I mean how long does it confer protection in general? Contoh you bagi DTaP kan, bagi DTaP kat the child. How long will she or he be protective from pertussis? Any guess? Korang ni silent sangat lah. So, any guess? Come on. Zulaka, cepat.
Long life protection.
Hey, your friend dah present tadi kan? What's the difference between natural between natural active natural and active artificial? What's the difference? So your female friend dah present the first one tadi. Your girlfriend.
Active immunization means the patient produce antibodies.
Ya ke? Okay, true. Active immunization means ourselves produce our own antibody. Okay. So what's the difference between artificial and natural?
Artificial ones, we introduce the antibodies to
The
the
antigen. We introduce the antigen or the
Mm.
organism, kan? So how long does it last?
active.
Artificial. How long does it last?
For the artificial is it takes about weeks to months of immunity.
That's to develop. How long does it last? How long does the IgG last? Ramai gila you guys. Okay, Syed, how long does it last? Siapa yang present tadi? Ayo, you guys ni. I see your friend mention tau tadi.
For diphtheria, around 10 years.
Usually about 7 to 10 years lah. At most is 10 years. That's why itu bagi booster. That is if you give booster. Remember? Kalau you tak give booster, it's only last 6 months je. Every time you jab, it lasts about 6 months. Okay. And then if you jab another one, it lasts about it will last longer lah. You boost the memory B cell. And then if you jab another one, then it lasts longer. That's why you need booster after a while. Most vaccine, actually all of these vaccine, you need booster in adult. Okay, in adult definitely you need booster. Okay, kalau tak, you won't be protected for lifelong. Because this is not lifelong protection. That's why you guys pernah tak batuk yang lama, batuk lama sangat sampai few weeks atau 2 minggu, atau maybe you guys punya antibody kuat. Tapi like myself, pernah je batuk lama, and that's most likely I've got pertussis, faham tak? Because you only got a temporary protection from pertussis. Because all this condition kan, all this we call vaccine preventable disease, all this disease are actually very dangerous if it affect young children. Okay, that's why we are protecting them, young children and all children. All children, sorry, young children and all people. So these conditions, this infection will kill this population, the very young one and the very old one. So that's why we give vaccine to these two groups, especially the young ones. The young ones to protect the old, and because if it affect us, contoh kalau kita kalau some of us kena pertussis, you dapat batuk je lah, you akan jangkit ke orang, tapi you akan batuk je lah, nothing more. Okay, tapi kalau baby 1 year old, 1 month old dapat pertussis, they can get cerebral hemorrhage, they can get apnea, they can die. Sama macam measles, you boleh dapat measles. We can get measles because we give life attenuated vaccine kan, so the punya effect dia not as long term compared to natural immunization. Okay. Okay, so nanti semua Aina tadi you check CDC, and then you tell us. You boleh snap je the whole one page dekat CDC tu, and then post dalam group lah. Okay, so let's proceed with our abdo exam. Ada any questions? Any other questions? Soalan? Okay, kalau tak ada, then let's proceed with the abdo exam. Okay, actually I've prepared, not I prepared lah, I've download from YouTube abdomen examination. But before that one, I need a bit background of your, to know a bit of your background knowledge lah. So this is your what posting? How many posting have you done this year? As third year.
Third posting.
So this is your third posting lah. So you did, I believe you did IM and
ONG and surgery.
Oh, okay. ONG and surgery. Not that useful. Anyway, so tapi okay lah, ONG maybe a bit useful lah, the surgery. Okay, so Okay, how do you take history? Okay, let me call names. Okay, start from Taufik Fauzi. Okay, how do you take history? So what, kita physical examination kan? Okay, how do you do physical examination? Taufik.
First, you have to inspect
Inspect apa?
the general appearance of the patient.
Do you start from general appearance of the patient ke? What do you start first? You enter the room, what do you start first? When you start your examination, apa yang first kali you start? You ada flow kan? Okay, definitely you can ada flow lah. It has to be start with inspection, then only you touch patient, and then you palpate, percuss, and auscultate. So that's the flow. Okay, but you start from away, from far. Okay, you start from far. So mesti dia jauh daripada patient. So what the first step is, we call general inspection of the surrounding. Why is it important? Okay, tu orang lain lah. Laili Safi. Why is it important? Inspection of the surrounding.
To make sure the patient is comfortable.
No, you don't look at patient first, okay? Because this is exam lah, in exam lah. But in real life, definitely you look at patient first. Tapi in real life, in exam situation, first you have to inspect the general surrounding, the surrounding. Why is it important?
Surrounding of the patient.
Apa dia?
To make sure the privacy.
The what? The what?
The privacy of the patient, like there is no one else there.
Oh, no lah. Apa kita guna look? I mean, why do you have to look at the surrounding of the patient? It's nothing to do with patient privacy. Chat. Why do you have to look at the surrounding? Near the patient, beside patient, above patient, underneath patient. It's very important, you know. In fact, you can get the diagnosis just by looking around. Okay, Khairul, apa dah? Nadia kot.
I think we can we can get the first impression
First impression
of the patient condition.
How by looking at surrounding you can get first impression. I mean, you can build first impression.
So
No. When you examine patient, the first thing kan, when I ask you, okay, now please examine this patient abdomen. Okay, first of all, I got a question. Okay, this is a 5-year-old boy presented with lethargic. Okay. So please an abdominal distension. So please examine this patient's the child's abdomen. So what the first thing you have to look at? You have to look at the surrounding. You have to look at the room besides the patient. Look at the surrounding first before you approach the patient. Okay. Stand at the bed, at the end of the bed, okay, and look at the surrounding. Okay, that's the first step. Why? Okay, basically to get clues kan. You want to get clues. How is the patient condition and what is the disease? What's patient suffered from? Okay, for example kan, you datang, you tengok daripada backside, you nampak, oh, patient ada insulin pen. You tahu, oh, patient ni ada, you nampak dia satu pen. Oh, patient ada insulin pen. So you tahu lah patient ni diabetes kan. Atau respi, contoh the station is respi station. Look around, make sure you take times, don't take so much time lah, take about like 10-20 seconds. Look at the surrounding, make sure you're familiar with all the equipments and make sure there must be something around that give you clues. Contoh you tengok, oh ada MDI, dia tahu oh patient ni asma. Oh ada naps hanging, then ada nebulizer punya set kan hanging. Dia tahu patient ni require nebulization, so possible dia asma. Atau patient ada walking aid. Oh kenapa patient tak boleh jalan? Tapi kaki tak ada plaster, there's no plaster of Paris. Kan tak ada cast. Then chances are patient ni mesti neurological problem. Itu tak boleh jalan. So, because this will give you clues tau. This will give you clues. Okay, contoh patient tu ada blood kan, ada apa infusion set, ada blood giving set hanging. Then you tahu oh patient ni require infusion. Oh mesti thalassemia lah ni. That will give you a lot of clue. In fact, diagnosis. Okay. Okay, next. Okay, you look surrounding for like 10-20 seconds. Okay, and then only you approach patient. Go to the patient. So what is the next step? Nurul Hanan. Okay, first look at the surrounding. Second, look at the patient. So what are you looking at? What are you looking for? Rather than that. So Nurul Hanan.
Look at the patient's general appearance.
Okay, what are you particularly looking at? Okay, this is abdominal station. Okay. Okay. For especially for abdominal station, what are you looking at? Sorry.
The patient is any distended abdomen.
Okay, before that, yang tu abdomen tu you dah tengok dekat abdomen tau. Now you looking at the patient. Okay, even before you expose patient, you look at the patient first. Contoh patient pakai selimut kan, so you look at the patient. What are you looking at?
Is the patient conscious?
Okay, good. Conscious level kan, lagi?
Conscious and alert to the surrounding.
Okay, good. You don't want patient looks encephalopathic kan? Sometimes you look encephalopathic macam lost. Nampak patient tu macam lost. Tanda dia encephalopathic. Okay, apa lagi?
Then see if patient has pallor or
sinuses. Okay, boleh lah. Tapi ni kan abdomen exam kan? Okay, tak apalah. Pelo lagi. What else? Look at the color kan. First, conscious level. Okay. And then the color. You buat macam ni, A, B, C, D. It's okay the A, B, C, D. First A apa? Airway. So kalau patient still can talk, looks comfortable, then you tahu airway, there's no abnormal sound, then you tahu airway pattern. Then look at B. B is breathing. Respiratory rate is very important. In all of the examination, respiratory rate is very important. Okay. Including in abdominal examination. Patient yang ada acidosis kan, yang ada liver failure atau acidosis, then they can be tachypneic kan. So breathing you can tengok patient comfortable ke tak. You may not need to actually calculate the breathing rate kan, to count the breathing rate, but you need to actually comment on the breathing. Does patient looks comfortable? Breathing, is it shallow breathing or is it small breathing? Okay, faham? So look at the breathing comfortably ke tak. And then look at the color lah. C is color kan. Color, look pink ke, jaundice ke, pale ke, sinus ke, color. And then what else? Look at the D is disability, alertness. Okay, D is alertness, conscious level. Especially look conscious, alert, orientated. Does patient look encephalopathic ataupun comatose, obtunded? Okay, use a good vocab, use your vocab correctly lah. Use medical term. Okay, pasal apa ya? So A, B, C, D, and then you look at the body habitus. B is body habitus, especially in abdominal exam. It's very important. All of the exams is very important, but in abdominal examination, especially more important lah. So body habitus, comment whether the patient looks sick ke tak. I mean, you tak buat any commentary kan, so later lah. Tapi you kena tengok, is the patient looks sick, look ada moon face ke, ada buffalo hump ke kalau you nampak from far, ada obvious acanthosis nigricans ke kat leher dia kan, nampak ada blackish discoloration. So is it acanthosis nigricans, ada obvious drying ke, hyperpigmented, okay, ada bruises. So these are the things that you have to comment. Okay, and habitus is very important lah. Nampak dia macam carrot on stick kan. Yeah. Orange on stick, carrot on stick. Okay, orange on stick. So nampak dia ada central obesity with thinning of the limbs. Then you describe that. Jangan sebut macam lah. Of course some description macam toad face lah, monkey face. Don't use that description lah. Tapi you have to look at the patient overall. Okay, lepas tu, after that, Tuan Fadil.
Next, approach question sudah. Okay.
This is
Lepas tu,
abdominal examination.
abdominal examination ke macam ni?
This is abdominal examination. So my question is, okay, this is Ali, a 5-year-old boy who presented with lethargic. So please examine this child abdomen. So how do you approach?
First, intro dulu, bagi nama, okay. Lepas tu kita nak check. Lepas tu kita akan minta permission daripada mak dia ke.
Good, very good. Consent, okay.
Lepas tu first we do kita cakap lah apa yang kita buat. Lepas kita cakap tu, and then try slowly approach. First start with inspection dulu.
Okay.
Kita tengok whether
inspection you divide into 3 lah kan. Inspection you divide into 3. Okay, first general surrounding of inspection of the general surrounding, then general inspection of the patient, then closer inspection. Okay, now you did the 2 kan. You did the 2. Now the third one is the closer inspection. Okay, closer inspection is when you inspect the hand, the specific body lah, body part. Okay, so sekarang ni this is abdominal examination. So you nak start daripada mana?
Daripada atas.
Atas maksudnya?
Dia macam kuadran mak, yang ada part-part dia tu.
Okay, tak. Okay, yang tu kalau you dah start abdomen. Okay, ideally kan in any exam, you start from the periphery. Okay, you start periphery. Start dengan tangan dulu. Unless kalau examiner kata, no need. Please proceed to the abdomen. Then you proceed to abdomen lah. Tapi in your case, your station usually about 10-20 minutes kan. You got a lot of time. So start from periphery, start from the hand. Okay, first kali inspect the hand. Okay, tanya dia. First kali tanya, okay, is there any pain? Adik ada sakit mana tak? Oh, tak ada. Okay, kalau tak ada, boleh tak doktor tengok tangan? Then ask for the hand. Kau boleh kan, you minta tangan. Jangan you pegang tangan, you minta tangan dia. Can you show me your hand? Okay. So at least you boleh assess dia punya understanding, dia punya conscious level kan. And then dia bagi tangan dia. Okay, that's a sign yang patient ni alert and orientated. Okay, kalau you minta tangan dia punya kaki, then you tahulah, oh patient ni dia lah learning disability ataupun dia unconscious lah kot, dia tak alert kan. Okay, so you tengok kat tangan. Okay, first you tengok tangan. What are you looking at the hand?
Any bruises?
Okay, bruises. Ya ke bruises? Kita tengok tangan.
Tak. Apa macam merah-merah.
Apa ni merah?
Sekejap.
You guys baca tak sebelum masuk kelas ni? Baca kan?
InsyaAllah.
So budak UIA ni rajin selalu baca. Okay, so you tengok tangan kan? You tengok tangan and then you tengok. Okay, apa you tengok kat tangan?
Yang ni scar.
Mana pula scar?
Tak. Sorry.
What are the things that you can access from the hand? Apa benda yang you boleh access daripada tangan?
Clubbing.
Clubbing, good. Okay, clubbing, good. Tapi
Really
before
not.
apa you do with clubbing? Because clubbing
Ni.
affect life and death. Apa yang
ni?
affect life and death? Apa dia?
Cyanosis.
Cyanosis, actually kita tak check di tangan cyanosis. Cyanosis kita check kat mulut.
Oh, kat mulut
Kat mucosa, tang.
Oh, tang. Lepas tu palma.
Okay. Palma apa?
Palma erythema.
Okay, palma erythema. Okay lah, palma erythema. But it's not common in pediatric. Tapi okay, you kena mention lah, there's no palma erythema. Palma erythema means redness lah kan? Okay, apa lagi you boleh tengok kat tangan?
Signs of tapi pale kena tengok tu kan.
Pale boleh tengok kat tangan.
Pale boleh. Okay.
Okay, lagi.
Sayyidatul
ni. Okay, Sayyidatul lah. Sayyidatul is apa?
Yes, doctor.
Apa you boleh tengok kat tangan?
Maybe we can assess the patient's hygiene, look whether they cut their nails, whether they bite their nails.
Okay lah, boleh. In abdominal examination, okay lah, I accept. Okay. Dah takut ada pika ke kan? We don't know. Okay, but usually we don't comment on hygiene lah kat tangan. Tapi it's good, that's very good. Okay, lagi what else? Kat tangan.
Sometimes.
You boleh access hydration, periphery dia warm ke cold, kan? Kalau patient in shock, what do you expect the hand will be? Cold, clammy, kan? Tapi kalau dia good perfusion, then you boleh nampak warm, flushing, red, tak ada flushing, red, pink, warm, very moist, kan? So you kena comment, good hydration, muscle bulk dia okay ke tak, normal muscle bulk, tina, hypotena, eminence ni apa atau prominent eminence ni okay, normal. Kalau adult you ada Dupuytren contracture, you ada palmar erythema, semua benda lah. Tapi pediatric tak banyak sangat. And then you kena measure, you kena assess dia punya perfusion, cap refill kan, capillary refill time. Tahu capillary refill time? Check for dia. Capillary refill time. Is it immediate ke ataupun delayed? Okay. Pasal apa ni? You check for clubbing. You mention tadi kan, clubbing. Okay, what else? And then you boleh suruh dia angkat tangan, look for flapping tremor. Okay, flapping tremor, sign of chronic liver disease lah. Okay, flap. Okay. Flapping tremor. Okay, pasal apa lagi? Okay, tangan dah. Pasal nak pergi mana? Check for heart rate. Okay, check for heart rate. Kita tak nak patient in shock lah. Check for heart rate. Okay, feel for heart rate. And then offer. Can I know the BP? You bertanya. Can I know the blood pressure? Okay, ataupun I would like to check the blood pressure. Itu tak payah. No need. Then tak mau proceed. So then why do you want to check for blood pressure? Macam patient may have hypertension because of abdominal mass ataupun apa tu? Neuroblastoma or phagocytoma, I don't know. So just mention blood pressure, unit lah. Okay. Lepas tu apa lagi? You boleh pergi and then you tengok dekat muka. After hand, go to the face. Okay, what you looking at the face? Anis Amira.
Mula-mula first check for the eye. If the patient is in pallor or any sclerotic jaundice. And then check for the mouth. If there's any ulceration or So next check for the tongue. If there is any glossitis, for example.
Good. Lagi?
Tu je.
Glossitis kan, angle of the mouth. So tengok angular stomatitis, glossitis. Oh, sorry, ni abdomen exam kan. So tangan tadi kena komen on apa? Tangan. Apa you boleh komen on tangan?
Colinokia.
Colonokia lagi.
Leukonychia.
Okay, lagi. Jadi baca lah apa colonokia ni, baca lah, yang malas nak beritahu. Mana you baca? Okay lagi?
Tangan.
Kat tangan panggil. Okay, good Anis. Okay, good. Dekat muka tadi, apa you tengok tadi kat muka?
Mula start with the eye. Oral.
You tengok for jaundice. Lepas tu you tengok conjunctiva. Look for pello. Either conjunctiva pello atau conjunctival suffusion lah, suffusion atau flushing. Okay lagi?
And then check you.
You nak check apa?
Ada.
You tak payah kot. Okay, boleh kat sini you boleh tengok oral hygiene kan, dental hygiene dia macam mana, oral hygiene. Gum. Kalau ada gum hypertrophy, takut dia ada scurvy kan. Ada gum gingivitis. You boleh tengok. Okay, sebab GI ni when abdominal examination ni including children with GI problem lah, absorption problem, malnutrition, these are all under abdominal exam. Okay, lepas tu next you boleh pergi dekat abdomen. Okay, straight after face you can go to straight to abdomen. But you boleh tengok dulu, kalau you kena expose, lupa pula. Before you examine patient, you kena expose patient dulu lah. Okay, ideally expose from the inguinal to the nipple, sepatutnya lah, ideally. Okay, ideally kita nak tengok dia punya genitalia juga, tapi genitalia biar cover dulu. Yang kena expose abdomen sampai nipple, you kena expose. Cuma you kena tengok dekat chest. Okay, look at the chest. Okay, look for any evidence we call stigmata of chronic liver disease. Apa stigmata of chronic liver disease? Tengku nurin. Apa dia? Ada sign of chronic liver disease.
Spider nevi.
Okay, good. Okay, okay, you boleh check kat chest spider nevi.
Gynecomastia.
Good.
Apa yang
sometimes you boleh dekat tangan you boleh nampak patient ni edematous kan. Kalau patient ni edematous kat tangan, kat edema, then you boleh mention lah edema. Okay, apa ni tu dah basically tu lah gynecomastia.
Caput medusa.
You look at the abdomen, look at the umbilical, peri-umbilical area lah, bukan dekat chest. Okay, then you go to abdomen. Okay, you inspect the abdomen. Okay, Aina Zati dah ni. Okay, Hafiz Syafi. Okay, what are you looking at the abdomen?
So we check the shape of the abdomen first.
Okay,
is there any
how do you describe the shape?
Is there any masses or distension?
Okay, any distension lagi? You tak pegang lagi tau. You inspect. Okay. You inspect for mass. You tak inspect for mass. You look at the shape kan. Comment the shape. Whether the shape is distended ke tak. Okay lagi? Scaphoid. Okay, lagi?
We see for scars.
Okay, good. Look for scars. What scars you want to look at?
Any surgical scar?
Yelah, dekat mana? Surgical scar can appear.
At the flank for the renal.
Okay, at the flank for renal. Okay. Look at abdomen. Anterior.
The anterior for the liver. Liver biopsy.
Anterior and liver biopsy. Okay. Liver biopsy ni scar kat mana? Liver biopsy ni scar tu pada time tengok dia tak ada. It's very small. Okay, lagi.
And then appendicitis for appendicitis.
Okay, kat mana appendicitis punya scar? Appendicectomy punya scar kat mana?
Right iliac.
Right kat McBurney kan. McBurney point. Lagi apa lagi?
Any laparoscopy scar?
Laparoscopic scar. Okay lagi. Laparotomy punya scar. Okay, midline scar kan. Midline scar, rooftop scar. So you can tahu all the name of the scars. Okay. Balik ni baca what are the names of all these scars and what are the indication. Okay. So you kena tengok scar. Lepas tu you kena tengok dekat hernia. Kat inguinal punya area pun you kena tengok. For herniatomy punya scar. Angiography lah. Pediatry. Angiography punya scar. Okay. And then lepas tu tengok dekat peri-umbilical. Okay, kalau pernah ada gastroparesis ataupun ankylosing repair. Look for the scar. Okay, dekat belakang you kena tengok lah. Yang macam you mention for any kidney punya scar lah. Ataupun any renal transplant in scar. Okay, good. Lepas scar, okay, you boleh touch. You start, okay, sekarang you dah inspect, you palpate. So, macam you start palpate? Ilya Maisara. How do you palpate the abdomen?
Should use the warm hand.
Okay.
Away from the pain.
Apa dia?
For the we can start from the left iliac.
Left iliac fossa. You start dekat left iliac fossa.
Left, right.
Okay, actually kan there's no rule, black and white rule kata where to start. But remember, the most important thing is start away the farthest from tender side. Okay, so you kena tanya dia, adik ada sakit kat mana tak? Oh, ada sakit kat mana? Cuba tunjuk. Saya kat sini. Okay. Jap. Sekejap. Okay, so jap. Ada ni nak kena pindah jap. Okay, so you start away from the tender side lah. Okay. So tanya ada sakit mana tak? Kalau tak ada, then you start to palpate. Okay, start dengan superficial palpation and then deep palpation. The method kita akan tengok video nanti lah. Okay, start dengan superficial. Okay, start superficial. Okay, every quadrant. Okay, every quadrant. You ada berapa quadrant kat abdomen? Fatin, ada berapa quadrant kat abdomen?
9 quadrants.
Then you start dekat, you palpate all the 9 quadrant kan? Okay, lepas apa lagi? Okay, lepas tu? Okay, what is the reason behind superficial palpation ni? Kenapa kita buat superficial palpation?
Nak tahu area mana yang tenderness.
Okay, good. Okay, untuk check for tenderness. Okay, lepas tu kita buat deep palpation pula kan? Okay, deep palpation. Kenapa dia buat deep palpation?
To check for any organomegaly.
Okay, any mass lah. To appreciate any mass. Okay, any mass. Okay, lepas tu, after that, kita buat apa? Abid, Yunus. Abid ni.
Lepas kita palpation dah habis kan doktor?
Deep palpation habis, yes.
So maybe we can move to the auscultation.
Mana buat auscultation?
Belum.
Palpation tak habis lagi. Baru palpation of each quadrant. Now you have to palpate organ pula, faham tak?
Oh.
Lepas you palpate the quadrant, you palpate the organ. So what organ you have to palpate?
You can palpate the liver.
Okay, liver start from where you begin. Where you begin palpation? Where you start your palpation?
Kalau kat liver, you begin at the right hypochondriac.
No lah. Liver kan dia grow downwards. So you start dengan right iliac fossa lah. You start daripada right iliac fossa. Kan? So you palpate right iliac fossa, follow dia punya breathing. Okay, nanti you tengoklah video. Later kalau kita buat face to face, I will demonstrate lah. Tapi now I just give you the background theory lah. So palpate from right iliac fossa upwards. Okay. Sampailah ke costal margin. Okay, the costal border lah, costal border. Okay, lepas liver, okay, liver once you feel the liver kan, you have to measure the liver. Satu, you have to measure. You have to appreciate the surface of the liver. Okay, is it rough or is it smooth or is it firm? Is it hard? So you have to describe that. Okay, then you measure the liver. Okay, measure the liver span. Okay, lepas tu you palpate the spleen. So kalau spleen you palpate from which quadrant? Nurhanis. Nurhanis, okay.
From the left. Left quadrant. Left upper quadrant.
Left upper quadrant. Yeah, spleen.
Spleen. Right iliac fossa to the left subquartal margin.
Betul. Faham? So start dengan right iliac fossa sampai ke left costal margin lah. So you palpate. Okay. And then macam nak, once you felt something, then you have to measure. You need to measure again. You need to measure. Describe the the texture. Was it firm? Is it firm ataupun hard, smooth ke tak? And then, okay. And then you kena how to identify the spleen. Macam nak tahu to spleen rather than any other mass.
See the consistency.
Okay, macam mana consistency spleen?
It should be solid.
Dah. Okay, lain. Selain. Macam nak tahu tu spleen? Macam nak bezakan spleen dengan kidney?
Look for the splenic notch.
Good. So feel for splenic notch kan? Kat mana splenic notch? Salah, 10 minit je lagi. And then kita betul video and then kita habis. I rasa you guys are bosan. Okay, tak apa. So, kat mana you macam mana nak kenal splenic notch? Macam mana nak palpate splenic notch?
I'm not sure. Sorry.
Okay, tak apa. Nanti Yanis you baca. Okay, Akil Ikram. Okay, how to differentiate? When you felt something at the left side, okay, how you differentiate between spleen and kidney?
Like Ani said before, find the detect the splenic notch.
Okay, lagi? Apa lagi? Kalau you pekas macam mana? If you pekas spleen dengan pekas kidney, what's the difference? Okay, tak apa, you baca nanti. Okay. Okay, I nak you baca. Okay, Akil Akram, I bagi you homework. Okay, how to differentiate kidney and spleen from physical examination. Okay, splenomegaly and nephromegaly, how to differentiate those two. Okay, from physical examination. Okay, nanti you bagi tahu dalam group. Okay, nak you bagi tahu semua kawan-kawan you. Di WhatsApp dalam group you. How to differentiate the two. Nanti I tanya, I come back random. Budak third year, I tanya, ada tak you share? Okay, kalau tak ada, I akan tolak markah. Okay, Syakira Amira. Sama, yang tadi pun sama ya, Aina tadi. Make sure you share dengan semua kawan-kawan you. Dengan I sekali hantar kat I, dengan hantar kat all your friends. Homework. Okay, Syakira Amira. Okay, okay, you dah palpate spleen, palpate liver. Now you have to do what? What other organ you have to palpate?
Other than liver and spleen, kidney.
Kidney. Okay, how do you palpate kidney?
For the kidney, place the one hand under the patient in the right flank region, and the other hand on the top, and try to ballot the kidney between the two hands.
Okay. Ballot means what? You yang tangan mana yang you feel? Tangan mana yang feeling the kidney, or tangan mana yang ballot? You ballot from bottom atau from top?
Tak tahulah, tak sure lah.
Okay, check. And then share juga nanti. Share dengan I and share with your friends.
Alright.
Okay, Huda Yasudin. Ya, Yasudin. Sorry, Huda Yas. Nampak nama itu? Yasudin. Yasudin. Apa dia?
Doktor tanya apa?
Tak ada dia jawab Siapa?
Saya. Huda.
Okay, tak apa. Okay, so Huda Yasudin. Okay, after you palpate the organs, kan, to determine whether presence of organomegaly, then what else you want to do? Now what you want to do?
Kita buat percussion.
Okay, percussion. So what you want to percuss?
For any presence of ascites, such as shifting dullness.
Okay, good. Again.
And also
before that, you kena perkas organ dulu lah, faham? Kalau you, if you find an organomegaly, contoh you find liver kan, atau you find spleen, then you have to perkas. Confirm your palpation with percussion. Okay, you perkas sama je macam palpation tadi, tapi you perkas to determine to confirm the megaly lah, the organomegaly. Then only, okay, lepas you perkas tu baru you perkas for ascites. Okay, so you buat shifting dullness ataupun you buat great thrills. Okay, good. Okay, next apa lagi? Lepas tu, you dah palpate, you dah perkas. Next, you, Farah Anis.
Yes, doctor. Next, we auscultate.
Okay. What to auscultate?
Auscultate the vowel sound.
Okay, where?
At the Macam mana?
Macam? Macam ni.
Static bowel sound. Is it present or not?
Okay, kat mana you nak auscultate untuk bowel sound?
Dekat dia punya volume.
Apa dia?
Ada that volume.
Okay, doesn't matter actually. Actually, you boleh auscultate kat mana of the abdomen. As long as ada intestine kat situ, then you boleh auscultate lah. Okay, jangan you auscultate atas liver dah lah. You just as long as you tak auscultate atas liver or spleen, doesn't matter. Okay, besides bowel sound, what else you kena auscultate? Renal buoy kan? Okay, you kena auscultate renal buoy lah. So renal buoy, you auscultate, just auscultate dekat right and left iliac fossa, that area, nanti you dengar lah bunyi tu. Okay, kalau ada. Okay, ada questions tak? Before, okay, lepas tu what else? Lepas you examine abdomen, you kena examine dekat inguinal region. Look for hernia. And then you boleh assess lah hernia by cough kan, cough reflex. And tu you baca lah. Okay, good. So I rasa tunjuk video lah. So it start to get boring. Okay, actually lah, physical examination ni you have to do it. Okay, you have to observe it, you have to do it, and then you have to practice. Kalau I cerita je and then you pun tak baca, then no point lah. I rasa tak banyak benefit. So sekejap I tunjuk you video. Mana? Oh, here. Share screen.
Doctor. The sound is not clear.
Oh, ya ke? Sekejap.
Okay.
Macam mana nak buat? Okay, buat. Okay tak?
Still not.
Clear tak?
Tak.
Sekejap. Sekejap apa?
Not yet.
Sekejap.
Okay.
Clear tak? Sekejap lah. Okay, dengar tak tadi?
No,
Tak dengar langsung
tak clear.
Tak clear. Saya dah kuatkan volume pun tak clear tak?
No, still not clear.
Macam mana? Terpasang kat internet lah. Sekejap, pasal ni ambil di YouTube je pun. Sekejap dekat YouTube lah. Hold on. Okay, dah dengar tak? Guys, dengar?
Tak sangat.
Tak.
Saya rasa tengok sendiri lah sekejap Okay. If that's the case, you tengok sendiri lah. Okay, I rasa you tengok sendiri lah, letak kat chat. Ada YouTube je lah semua, tapi tak payah letak link dekat chat. Okay, just watch the video. Okay, it's not 100% standard lah. I mean, this is a brief one, but focus on the technique. Okay, because of course Malaysian we love to do more kan. Macam konon bagus sangat. Tapi anyway, so just watch the video, look at the technique. Okay, look at the technique, especially the palpation technique. Cuma the tips is in abdominal examination, the abdomen should lie at your eye level. So you kena either raise the bed ataupun you duduk, kneel down. But your eye should be at the abdomen level. And then you palpate. Jangan guna point of your finger the tip of your finger, because it's painful. So use the hand. Use the hand, palpate using your hand rather than the tip of your finger. Okay, lepas tu, and then when you're doing superficial palpation, your face should look at the patient's face, not at the abdomen. Look at patients, because you want to look for tender point, okay, rather than mass. Kalau deep palpation, baru you look at the abdomen. Okay, lepas tu apa lagi? And then macam tu je kot. So you boleh tengok video ni sendiri. If you got any questions, you can ask me. So ada soalan tak?
Doctor, one question.
Ah.
Are there any difference between abdominal examination on a normal patient and on pediatric patient? Any precaution ke or
Okay.
semua tu lah?
Okay, in pediatric, okay, the most important is don't cause pain. Okay, if you cause pain, you fail. Tu je. Number one is don't cause pain. Okay, number two is the different The different is you don't see much findings in pediatric. Especially kalau you expect nak tengok chronic liver disease punya findings kan, Kapok medusa semua. You won't see that. You won't see as much lah. And then there's a lot of scar. Kalau pediatric dia banyak scar compared to adult. Adult biasanya these are self-inflicted disease atau hepatitis C, jarang lah ada scar. Kalau pediatric banyak ada scar. Contoh post kasai kan, biliary atresia yang post kasai ataupun yang ada liver biopsy ke appendectomy. So dia ada more scar lah compared to adult. And then what else? And then tu je kot. Dia sama je. The flow of the examination sama je. Pediatric atau ni sama.
Okay, thank you, Doctor.
Okay. It's important. One of the but in what's the different? Another things different between adult and pediatric is when you observe kan, when you inspect general inspection, you have to comment on growth. Okay, in adult kita tak bother sangat growth, tapi in pediatric you have to comment on growth. Contoh budak ni 8 tahun tapi looks very small. Then you mention the child appeared small for her or for his age. Okay. However, I would like to confirm the height and weight by plotting on a proper growth chart. Okay, lepas tu tu je kot. Anything else? Nanti you tengok lah, make sure you tengok. Sebab by the time you datang untuk face-to-face session nanti, we expect you to know how to do physical examination. So balik ni you tengok, and then if you got any questions, you can ask me lah. At least abdominal examination ni senang sikit. Last time I teach neuro exam online. Yang tu lagi pening. Atau Dr. Salihin, later you akan dekat dengan Dr. Salihin. Previously I yang ajar neuro exam. I find it very hard, so I bagi kat Dr. Salihin. Later you belajar dengan Dr. Salihin. Any other questions? Pasal you kena baca lah, you kena baca causes of hepatomegaly, causes of splenomegaly, causes of hepatosplenomegaly. So you kena baca. And pediatric and there's a lot more pathology compared to adult. There's a lot, hundreds times more. It's more than double the adults. Kalau adults kan, you ada abdominal examination biasanya apa? Hepatitis. Betul je lah kot. Hepatitis. Okay, thalassemia occasionally. But in pediatric, there's a lot. Causes of hepatomegaly in pediatric, there's a lot. Hundreds. Okay. The rarest one, you can get the rarest one or the most common one macam thalassemia. Apa lagi? Infection. And then tapi all the IEM punya causes pun banyak. Ada banyak IEM punya causes. The metabolic causes lah. Gaucher, GSD, glycogen storage disease. Apa lagi? You even about Pompe, LSD. Ada banyak sangat. So abdo exam can easily come out in exam lah. It's one of the common exam. Because most patients they are stable and they've got findings. Okay. And then kalau patient ni contoh lagi satu kan, a lot of them can have sign and symptoms, extra abdominal signs and symptoms. Contoh macam thalassemia. They've got a lot of findings from elsewhere lah, from periphery, especially dekat muka kan. Nampak jaundice, nampak thalassemia facies, the prominent cheekbone, all this can give you clues. So a lot to comment lah, a lot to observe and inspect. Okay, rasa tu cukup. Any last questions? Okay. Okay lah, rasa tu cukup. Okay, tangan atas beri kafar. Atas. Okay, assalamualaikum warahmatullahi wabarakatuh. Make sure you guys baca sebelum kelas tau. It will help. Sebab kita orang struggling untuk ajar you guys physical examination online. So you have to struggle yourself as well. Okay? Okay lah. Okay, assalamualaikum.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.